Good afternoon, Dr. Justin Cole. How are you?
I'm doing well. Nice to see you, Steve.
Likewise, Justin. So, thank you again for joining us and agree to participate on this Beating Melanoma project. And I just want to give everyone a brief introduction about Dr. Cole. So, Dr. Cole is a dermatologist and currently serves as a director and chief of medical dermatology for the Stanford Healthcare. And that's, I guess, based in Palo Alto, California. And in addition to seeing patients where Dr. Cole has an interest in melanoma early skin cancer detection program, and he is also the Associate Chief Quality Officer and as well as the Chief Experience Officer for the Stanford Healthcare and Ambulatory Clinic. In addition, I know that, Justin, you have a strong interest in artificial intelligence, and you sort of founded and lead the Stanford Translational AI Dermatology Group, and you also serve as American Academy Dermatologist Committee as a chair for the Augmented Intelligence Committee. So with that, welcome.
Thanks. It's a topic I'm passionate about. Thanks for inviting me and appreciate the chance to have the conversation with you, Steve.
So a couple of things, first, let's get down to the basic. You see patients almost every day, and you see a lot of melanoma patients. What do you tell them when they first walked in, when they're sort of just so scared and terrified?
I think you hit the nail on the head with the prompt and the question is, every patient, I think the most important thing that we do as clinicians and as doctors, we have to confront and recognize the human factor, the humanity in sort of that interaction. Yes, we're talking about melanoma, but actually what we're dealing with is what is that emotion, what is that forefront concern? And you're right, oftentimes it is worry. It's worry about, sometimes it's worry about the unknown. Sometimes it's worry about knowing too much, right? We think about all our patients who have access to the internet and Google and all the different rabbit holes that they can go down. And so I always start my conversations with I want to hear what's going on in your head. Tell me, what is it that you're thinking about? What's consuming your thoughts? What are you worried about? What are you scared of? What are you uncertain about? Let's start there. So it's never, I'm going to come in with my agenda and let me tell you about melanoma and what we're going to do. It's more of an inquiry of, I want to know where a patient is coming from. Everybody comes from different places. They're what they bring to the table and into their interaction there. And I think if we don't start with the core, what's most important, we won't get far. And so that's always how I start my encounters. Melanoma or anything, but particularly when it comes to cancer, and particularly when it comes to melanoma.
No, I think this is really important. We think we know, right? But in reality, we don't sometimes. And I think it's a lot better just to ask patient to tell us what's on their mind versus guessing. And I think there's something else you do this is a very, very powerful exercise. Just take a couple of minutes to sort of get them to build that trust, right? And once they feel they're being heard, and you form that bond, because then the patient will come back and you will listen to you and increase the efficacy. But no, okay, you listen to them at this point, right? And what do you tell them?
I think listen. Yeah.
Go ahead. After you listen to them, then what?
Yeah. I think, once we understand where that place of starting is, then it's kind of, what I like to do is, I say, this is where we're trying to get to. So we have where we start from. We have sort of what it is that we're going to get to from a high level perspective, which is that, we've addressed the issue that's foremost right in front of us, right? This acute situation that we're in. Usually it's a new diagnosis of melanoma. And we say, yes, we're going to address this. We're going to talk all about the details. We're going to answer all of your questions. I want to first talk to you about where we're going to get to. Where do we want to end up? We want to end up in this place where, we look back and we see, yeah, we traveled that journey. We're in a place where we're more aware and understanding of skin and cancers, why they exist, and we're empowered with all of the knowledge that's going to help us live our lives in a meaningful, full way. That's also cognizant of the risk going forward. So we will get to a place that is much different than where it is that we're starting. We're going to feel not scared. We're going to feel in control of our skin. We're going to feel in control of all the things that we can do that will help prevent or reduce the risk of skin cancers or the skin cancer melanoma coming back. We're going to do this in partnership. We're going to do this together, and that's where we're going to end up. And so what our path is how do we get from where we are today to that? It's not one visit. Sorry. It's a journey, it's a relationship, and we'll get there. Today, we're going to focus on this. So I like the idea of let's look at the big picture. And this is what we're aspiring to, because it takes away a little bit of the here and in the here and now. It's overwhelming at times, right? Even for us clinicians, Steve, sometimes we see complicated situations in patients where there's so much to go through, and we're never going to get through it in a visit and be able to answer everything and talk about all the different risks and benefits of this and that. And but it doesn't have to be all in one, right? It doesn't. I think there's a common misconception that, hey, got to get it all done in that one visit. It's not true. There's it's the start of a relationship. It's the start of a dialogue, and it's the start of a journey and a path. And so that's what I like to do after I listen.
Yeah, I always sort of acknowledge the fact that, this is, I always tell my patients, especially the ones that just got treated with melanoma, right? And when just diagnosed, got surgery, etc. And they're coming back for skin exam. And I always tell them, I know you have all this concern and fears, everything, but over time, you're going to get better. Time heals, right? And then also that every time they come back, they see every year they're coming back, the melanoma is not coming back once they reach the magic 5-year mark, their risk just goes down. And there's the psychological comfort they achieve over time. Yeah. No, so you touched upon all the psychological component. At the end of the day, you're a dermatologist, you got to look, and you're not a psychiatrist. And how do you do your exam? How do you make sure that you can detect skin cancer really early, melanoma really early? And what are some of the tools that you're using?
Yeah, that's a great question. So there's, the proof is in the pudding. After we address the, the sort of the emotional element, the space in the room, we still have to be good at what we do. And predominantly we use our eyes, right? Because our job ideally is to be able to help patients prevent skin cancers in the first place. But really our job is in what we call secondary prevention, which is to diagnose it early, be able to catch these things when they're in the stage of being recognizable, being more treatable in the early stages. And I love this part because we think of the examination, the act of being examined as a passive part on the passive exercise on the part of the patient, and an active exercise on the part of the doctor. And what I like to do is I like to try to make this a very interactive experience.
Yeah, me too.
And so that makes it more fun for me, right? More engaging for me, but also I feel like, right, the more our patients know, the more empowered they are, the better they are, the better we can be together. It's not about how good your doctor is. It's about how good you are together as a doctor and patient team. And so I'll always just, there's stuff going through my mind, and I'll talk through it. I'll say, hey, the first thing that I'm doing when I'm taking a look at you, I'm not even starting to go in and take a look at spots. I'm taking a look at you, trying to get a sense of your overall, sun exposure history. Do you have fair skin? Do you have light eyes? Are you actually a redhead? And so that's starting to give clues. And so even from far away, walking in the room, the examination has begun. And then in the conversation, learning more about our patients and where they grew up, what they do, what they like to do. There's also information and clinical information being transferred that way. And so just talking through as we're starting to engage in that sort of exercise is good. These are the reasons why I'm looking the way I am and asking them what I am. What I really like to do is then let's just say I oftentimes will start with the arm, because it's something that a patient and we can look at together. And I'll say, hey, we're going to look together. And I sometimes get quizzical looks. What do you mean we're going to look together? You're the doctor, you look, right? I'll say, no, actually, I'd love for you to hear a little bit about how I approach this, because you as the patient have full unfettered access to your skin. I can only see it when you're sitting here in front of me in the clinic room, right? But when you're at home, when you're on the beach, when you're, in on vacation, somewhere, you can see your skin after your shower. And so what I talk about, and as we look at your skin together, maybe that'll help you both be empowered in terms of how you look at your skin, but maybe help you spot something that you might otherwise not have noticed. Let's look at your skin. The first thing that I'm doing is not going into any individual spot, but really looking at the overall picture, right? Let's get a sense of the pattern. And depending on the patient, sometimes you can get a sense, if they're interested in art, we can use an art analogy, right? So we talk about a painting and what's in the foreground, what's in the background. The things in the background start to melt into the background, and the things that come forward are the things in the foreground, or other sort of examples depending on what might resonate with the patient. And so really the idea is, trying to get across the sense of pattern recognition, that we're looking for things that are unlike the others, this
Yeah, I
ugly.
call that ugly ducklings.
And so I think that's probably one of the most important points to get across is, the skin is full of patterns, and the patterns probably reflect some internal combination of genetics. They interplay with the environment. And so we'll get these patterns. And when we see moles that are parts of patterns or parts of families, we feel more comfortable with them because there's some rhyme or reason behind them. But when we start to see things that are just by themselves, or kind of a black sheep of the family, sometimes we'll say, right? They're an interloper in a gathering or a picnic. These are ones that we're saying, hey, there's no rhyme or reason for why you exist. What family are you a part of? And if they don't have a family, or if they're acting in an unusual way, they're growing, changing faster, they're doing things like itching all the time, causing pain or bleeding, then we really have to wonder what is happening with that. Why is it standing out? And those are the things that we need to be aware of. I do it in a slightly more sophisticated way as a clinician, because I have some tools besides my eyes that I can use, almost like a light microscope, to look at very specific features. But that's the pattern, is what is different from the rest, right? So the big picture is what's different from the rest. And if we can get our patients to help sort of look for that in the way that they can, then we're really somewhere, right? It's them not feeling like they're overwhelmed by the hundreds of spots on their body. Hey, these spots all belong. They're part of a puzzle. They're part of a family. What are the ones that don't belong? That becomes a doable exercise. So that's kind of the approach. And I really like making that interactive. And I say, hey, when I'm looking at this, you know, tell me what stands out to you. Yeah, that was also one that stood out to me. And I'll tell you, yeah, I wasn't worried about that one because takes longer, but I think it's well worth the investment, because it really does create that exercise of passive active to, hey, we're both in it together. It's a partnership.
Yeah, not to mention you take this opportunity to educate patient, right? And I mean, I think a lot of times that one of the things that patient complain the most is when we tell them to do monthly self-exam for those high-risk patients, they will sort of just give up. They'll be like, oh, I don't know what to look for, right? And it's so interesting that I recently have this new handheld camera devices that's with the tethered into this like a really large, like I think 30-inch screen. And when I do my exam, I basically put that device on, and you can see the dermoscopic images of the lesion, but you can beam it instantaneously onto the screen.
Ah,
So now, I'm doing the same thing, right? So I'm basically taking this device, capturing every single lesion as it move along, and the patient can see it in front of them and what I'm looking at, right? And I'm taking the time to say, look, this is totally benign because XYZ. This is like not even a mole, this is a lesion that we need to take off because, so, I think those interactions is really valuable to me. Yeah.
I like that. I like what you're almost, you're teaching in front of a class of one there, Steve. So it's
Yeah, I mean, I think
multitasking,
the
right?
best thing, we're going to talk a little bit about your interest in population-based approach, right? I mean, I think what we should do is we teach our residents, we teach our medical students and other fellow colleagues, and we should figure out a way to teach the general public, right? This is just about pattern recognition in a sense. So, let's shift gears a little bit. I know that you've done a lot of work. You've thought a lot about artificial intelligence, right? And it's ubiquitous. It's everything, like on the iPhone. It's on Google search. It's everything, right? And Amazon and Tesla, every tech company. What is the state of artificial intelligence in helping us to detect skin cancer, melanoma specifically?
There's easy answers and there's more complicated answers.
Give us the easy
We'll
one
start with the
first.
easy answers. The easy answers is that it's around the corner. It's around the corner in a way. When I say that, I mean things that are validated, approved by the regulatory agencies like the FDA that can be coming into a clinical sort of environment near you, whether that's in a primary care doctor's office or elsewhere. It's around the corner, and it's I would say the sort of the beginning of the idea of artificial intelligence and skin cancer detection. Probably it's more than six years old now, and so everybody thought, when that first started, just a little bit away, it'll be there. But it's taken 6+ years, 7 years to really get to the point where these tools are developed in a way that can be reliable, that can be safe, that can help patients. And I'm glad it's taken that long. Technology is oftentimes we think of, around me in Silicon Valley, it's fast, it's innovative, it's exciting. It's your car is going to be able to, drive you to the next destination and park for you, and you can watch a movie. I don't know that we want our healthcare like that, right? How many accidents have we seen and stories about, things going wrong with artificial intelligence that is being used in real life and harming people? I think it's actually a very good thing that it's taken us longer, and that it will be probably much more rigorous and controlled and sort of safe than just any other technology, right? We're not talking about Instagram or delivering food to your door. We're talking about people's health and livelihood and skin cancer, and these are life and death things. So that's the easy answer, which is, hey, it's getting closer. It's around the corner. How long it'll take for people and clinics and physicians to start using them and for people to start being helped, probably there'll be an adoption curve like most technologies, or there'll be people who take it up first, do some learning, will learn, hey, does it live up to its promise, or is it something that falls short and we got to deal with this issue and this issue that we didn't realize? There'll probably be some of that, just like any new technology. But I don't think it's far from starting to make some real impact in people's lives. The question about what kind of impact it makes is a different one. So we're not going to solve the skin cancer problem or the melanoma detection problem with AI. It's not a technology solved issue. It's something where the technology, the AI, can be a tool that clinicians and physicians and health systems and public health experts can utilize to help make a difference in right now areas where there is challenge. But it's not going to be sort of the solving the problem. And I'll tell you the two challenges that I'm most excited about AI making an impact in right now. The two biggest things is the people who can diagnose melanomas. There are very few of them, and they are very specific places. They exist in specific places in the world. And so if you are not so fortunate as to be a person in the world living near or accessible to one of those places where people can do that well, you're out of luck a little bit in your ability to access that expert level care. And so AI can be an extender. Think of it as an extender, something that makes it such that you can be, you don't have to be within arm's length of Steve. You can be further. You can potentially be across the internet, across the world, and be able to have access to the brains and the clinical capabilities that Steve can possess, especially when wielding a technological tool. So that's where I am most interested in and most excited by it. But it's again, it's never the technology itself. It's all the things that people take for granted. It's what happens after someone gets has a skin cancer detected. Where are they going to go for their care? If you can't, if you can't access a place where they can have the surgical expertise to cut out the melanoma or the medications to treat it, it doesn't really help us. Diagnosing it by itself is not the full answer. So it'll get us further along, but there's still a whole lot of work to be done, and work that's not technological work that is the hard work of building, of infrastructure, of design, of creating the workflows, of understanding how do we make doctors better with technology.
So one thing you talked about is solving the challenge with access that AI can help. What's the other one? You said there are two that you're really super excited. What's the other one?
Yeah, so there are two parts of access. So one is the geographic, thank you for bringing that back. So one is the geographic part of access. The other part of access is there's only so many hours in a day,
Sure.
and the number of clinicians. So the ability of technology is to say, instead of seeing and helping a patient on a one-to-one basis, I can help a patient, in a clinical interaction, but that takes time. And I do it in a one-to-one basis, one doctor, one patient helped. With technology, what if we let technology do some of the work of information gathering, for example, or pattern recognizing? Maybe I can start to help 100 patients in the same amount of time that I currently help one. So it's a way for us to scale the capabilities or to make doctors superheroes, be able to do more work with their brain power and to be able to create increased access.
Now, are you talking this specifically in the context, let's say, one way I'm thinking about this, right, is let's say, Justin, you're an expert and but very few patients have access to you, but they can access a whole bunch physician extender like the NPs and PAs, right? Now, the combination, if the PA and NP have an access to a handheld wand or device, they put on the lesions and they will tell you with certain probability whether something's benign or malignant. That will amplify it because that combination will be as good as you, basically, right?
Yeah.
And there's something else I think you're talking about a little bit more. That is, you're talking about this amplification process. That is this just much more than what I'm thinking of, or there's something?
No, I think it's sort of variations of that theme, where can we take sort of what exists in people's heads and brains and sort of put it into sort of a broader network. There is a slight difference in what I'm thinking about, which is how do we keep and enhance kind of that what humans do best. So there will absolutely be many cases and situations where we will still need that human expert, as good as the machines and the systems can be, probably pretty great at straightforward things, but things that are kind of a little bit unclear or not so straightforward, boy, still needs some interpretation, still needs the weight of expertise and experience. And the other thing that we can start to do is we can start to do new things, right? So right now, we just talked about doing a skin examination of the patient, taking a look, taking a look at the patterns, finding things that sort of stand out or don't belong. It takes a decent amount of time to do a very full comprehensive examination. But that's something that, for example, if we had the combination of some tools or systems that could do a scan or sort of an imaging of the skin, and then some smart systems that could help to do that first interpretation, then all of a sudden, as the doctor, what I get is what I really cared about, which is like, what are the things that I need to pay attention to? So instead of doing the 10 minutes, I can do the really highly value added 1 minute. Okay, that's the spot. These are the statistics and the analysis that back that up. Let me do the thing that I do best. And now let's talk about this spot that may be, weird. It's growing a little bit too quickly. What should we do about it? What are the options? What are the ways that we can work together to improve the health? So it's taking that 10 minutes of activity, 9 minutes probably less value added, 1 minute of high value activity, and saying, hey, you know what? Let's skip straight to the 1 minute for me. So I can do that 1 minute of value added activity. That's
And
kind of your extension.
and I think some of the technology, just for viewers out there, it's out there. So just to summarize, really give people some background. I mean, I know in 2019, 2020, there's a couple of Nature paper, JCO paper came out that they give, they sort of submitted a database of this lesions, benign, malignant, and they pitted the dermatologist, the experts against the machine. And some of the algorithm actually is done better than the experts. So that's one type of paper. And then also, Justin, some of the stuff you talked about, I'm sure you already know that, the CanField Total Body 360 device, you sort of step into the booth, 46 camera fire simultaneously, create this 3D avatar of your body. And there's like, at this point, there's a research phase, but you can basically sort of sort out all the moles on your body based on the size and different parameters, right? And then there's some preliminary studies showing that you can take certain really crude multivariate analysis and pick out, let's say, the 10 lesions out of the 100 that is really, really worrisome, right? So this is the value add. So it's everything you said is around the corner, basically. Okay, I'm going to do something really fun with you, right? So in preparation for this this talk, I want you to name all the limitations that AI has at this point in picking up melanoma. And I'll tell you why, because I actually yesterday in preparation for this, I typed in the chat GPT and asked the OpenAI this question.
I love
Let's
it.
see how many of those you get it right. I mean, how many of those that you get a match with the machine? All right, go ahead.
Let's see if I can do better than ChatGPT. I'll tell you,
The
I've been playing around.
limitation of AI in picking up melanoma right now.
Yeah, I'll
That's the
tell you one
question I posed to
limitation. So
ChatGPT.
one limitation actually is, this is getting a little a little meta here, but one limitation of AI like ChatGPT, which is we call generative AI, which means you type in a prompt and it's, you know, acting human and giving you an answer. Here's one thing: it doesn't recognize when it shouldn't be as confident as it is. So I know that when I type in questions to ChatGPT, it's going to give me an answer. It's going to sound like the world's authority. And I'm going to look at that as an expert and say, hey, that part is absolutely not right. That's wrong. And it's going to tell you in a way where you think it's right. So I think that's one limitation. And one extreme danger is when you don't know what you don't know, or when you think you know something that is not right. That's really challenging and dangerous, because we as humans, we put this probably inappropriate faith in all things technology. Hopefully a little bit less so these days, as we see some challenges with that. But just because it's technology doesn't mean it's right, doesn't mean it's good, doesn't mean it's beneficial. It's only those things if we proactively make it so. So humans have to be involved to make things better. Okay, so I think that's one downside. Here's another downside. It's really bad at performing tasks that it is not it has not practiced on. I'll give you an example of that. So Steve is representing a study that we did. It was actually back in 2016 is when we started that work. It feels like 2019, 2016. And so this was we'll call it an AI that was really good at separating and sorting things. Just you showed a picture of something and sorts it into the right bucket, often, many times, especially when we asked, is this a skin cancer or not? So we did that, you know, good sorting. And then you say, okay, I'm going to take, you know, some skin spots of someone who has dark skin. Sort these. It's going to say, hey, I'm really sure that I'm going to do this right. It's really bad. It's incredibly bad.
No, you're so accurate. I mean, I think one of the thing is those machines, those algorithm uses collective lesion, the database, largely from, let's say, Caucasian population, right? And if you take the same algorithm and you apply it to the African American, Hispanic, Asian skin, it is off. I'm using this AI as a research tool right now, and I'm just kind of impressed by how good it is to detecting just Caucasian lesions under the Caucasian individuals, but that thing is really way off when
off. Yeah. So there's cool stuff that, you know, that you can do to make it better, and in fact it just takes a lot of time, energy, and intentionality. That's some of this work that I'm passionate about with the research group here, is how do you actually close that gap? But it's a gap. The other way, you know, I think it's not only a gap, it's a dangerous one, and I'll tell you why. So there are folks, maybe if they're trying to develop a product to sell, what they'll say is, yeah, this is really good at this thing. Let's do this thing, and let's do it over and over and over and make it better and better and better. That's probably what would happen if we let capitalism take its course, right? And then we start to get technology that's really good on the stuff that it's seen a lot of. And the things that it sees a lot of are the things that are, you know, as we know in our clinics, the people who are able to sit in front of Steve or myself are not representative of the broad population of people in this world. Absolutely not. And so what we start to see is tools that get better and better for those patients and leave the vast majority of folks behind. And so that is something that I say is a weakness, but it's more than a weakness. It's a danger. It's a moral and an ethical wrong, I would say. And that's something that I think is particularly true about AI as a technology. It's like a self-fulfilling prophecy. It's a machine that just does better, but creates a gap in the process. So that's that. I would say, you know, you asked me for a lot of different ones. That's by far the biggest one and the most important one and the most dangerous one. And that's the one where we need to have lots of people like you and I sort of pulling those two things together and say, no, we can't let that gap become bigger. We need to close that. We need to use the AI for good.
I think this is a really interesting exercise because I have to tell you, ChatGPT spit out the answers much faster than you did. All right. And they took like 7, they put out 7 answers. And you give me 3, obviously,
Yep.
lack of time, everything. And but the really interesting part is the limitation that you pointed out was not included in the ChatGPT's answer, right? And some of them they had a really good ones. Like one of them is like it's a black box, right? You don't know what's in it. You don't really know what this machine is looking at, right? And but I think this is another like really cool example of showing that how we need to, especially as a clinician, need to be inserted in this process. We can't just let computer scientists sort of take over, right? And that's a really quick one. We don't have too much time left, but I really want to touch upon this aspect. You serve as a chief experience officer, right? And from your perspective, what do you see some of the barriers and the patients, especially the melanoma patients, face? And what are you guys doing to sort of close that gap?
There's a few. I'll make one modification. So I'm the physician partner to the chief experience officer, which means I get to bask in some of the glow, but also I get to work from the clinical perspective and leading that work. But I'm passionate about it's not just about the quality of the care, it's how our patients experience it, right? Because that does influence it. You can have the best surgeons, you can have the best clinicians, you can have the best diagnoses, but if you don't have those care relationships, we're really not going to get to where we need to be. So, especially for cancer patients, for melanoma patients, it is different, right? It is a different set of circumstances, of worry, of things that people are thinking about than if you break your arm, for example, or you have high blood pressure, diabetes. I think we have to recognize that there is a unique set of factors, and there's been some interesting writing. For example, if we just take one of those factors, the financial impact of cancer diagnosis, right? This concept of financial toxicity. That's one where, again, we think of ourselves, our jobs and our role as doctors. What is the way that finances interplace? It absolutely should, right? It absolutely should. If we don't recognize the financial realities, if we say broader, what we call these social determinants of health, the sort of the way that these other aspects of your life influence the way that you receive health care, that you are able to take care of yourself, that you're able to do certain treatments or not, then again, we're not going to get anywhere. I think it's a recognition that the patients who sit in front of us are patients even outside of that exam room. There are people in this world. And how do they experience the world? How does that interact with what we're recommending in terms of treatment or procedures? And even to the point of, are they able to follow through on those recommendations? Can they pay for their medication? Can they access it? Can they get back in for their follow-up visit if they have to drive 3 hours away? I don't know, right? So those are the ways that at least in my work now, really has broadened the view to, as doctors, yes, we're involved in that diagnosis, the treatment, the plan, the healing, all of that stuff. But boy, unless we open our eyes wider, we're really not doing our patients the service that we should, because we need to look at them as humans in the world, not just as people sitting in front of us in the exam room.
I think this is one of the most important things as a clinician. Sometimes we forget, we focus on the disease, right? We forget sometimes there's a patient, there's a real person in front of us. Justin, I can't thank you enough. I know that, this conversation is supposed to be looking at dermatology and melanoma, but you've given them much more thoughtful, psychological, emotional, sort of in-depth discussion about the patient and your philosophy taking care of patient. And I know we got into a lot of those AI stuff. And I know you and I can talk about this for a lot longer. And I just want to respect your time. And once again, thank you so much for taking the time and to chat with me. Hopefully have you back. And there's a lot of stuff we can talk about. We didn't even touch upon a couple of the questions. So gotta have you back.
Yeah, it was an amazing pleasure. I love the chance to talk in this way in this forum. I think it's brilliant what it is that you've done with this series and also the book. So congratulations on impacting lots of people's lives.
Well, thanks again. Take care.